All right, I think I'm going to get started. So as you all know, I work with a lot of children with epilepsy and autism, and is often the case with cannabis medicine. We see all these significant improvements, but yet these improvements are difficult to measure objectively. And so you may ask me, well, if a child's doing well and the parents are happy and the school is happy, why do we need objective measurements? And I think part of it goes to what Dr. Meckler was just talking about, which is the ongoing skepticism within the medical community. They are still somewhat resistant to patients using cannabis, especially children, still considered very controversial. I don't think so, but many others do. But the other thing, too, is wouldn't it be nice if somebody was spending $1,000 a month and seeing great benefits in their child if that was covered by insurance? And we all know, and I definitely see this, that insurance companies are not interested in paying for this, but I think we're saving the insurance companies a huge amount of money because these kids have much lowered healthcare utilization needs. I definitely see it in my pediatric epilepsy practice where these children are not ending up in the ICU every other month with status. So it would be nice if their insurance companies would pay for some of these medications for them. So I'm going to talk about my research in using metabolomics, and measuring salivary biomarkers to measure the impact of medical cannabis in children. So I think we all know about autism spectrum disorder as being this heterogeneous condition with increasing prevalence. Right now, the CDC says 1 in 36 children. This is 241% higher than what was reported 24 years ago. There's clear-cut evidence of inflammation in both the gut and brain, and currently there's only 2 FDA-approved medications, both antipsychotics, which have very serious short and long-term side effects. I have an 11-year-old patient in my practice who gained 40 pounds in about 3 months on an antipsychotic, and so it didn't help his aggression, it just made him bigger and stronger. And that's not really desirable. But if you're looking at really what are the issues with autism, we talk about the 3 core symptoms that are listed here at the bottom, and no pharmaceuticals address these, so communication difficulty, and I say in some because some people with autism communicate just fine. Impaired reciprocal social interaction and restricted repetitive and stereotype behaviors of pattern. We know boys are more affected than girls. We also know some of these patients have very significant above average intelligence, but some have intellectual disabilities. There's numerous clinical trials. Yesterday I talked about this in the medical practicum. This one particular review looked at 13 studies, and what they found, it's kind of hard for me to see this, 4 observational studies that showed that 70 to 93% of participants had improvement. This is a very high number, especially in this refractory condition that it really doesn't have very many options. 2 retrospective reviews showed 61% improvement rates in behavior, 67% improvements in those core symptoms, which pharmaceuticals do not treat. 3 studies show they're able to decrease dosing or discontinue other medications, and all studies demonstrated very acceptable safety and tolerability. And I don't have a slide on this. I talked about it, I think, yesterday. It appears that children with autism have an endocannabinoid deficiency. There's 2 studies, one from Israel and one from Stanford University, showing that they have lower levels of anandamide. And so remember what anandamide is involved with is pretty much everything that we need in terms of regulating emotional behavior. Also, endocannabinoids are involved in immune function, and we know that there's a lot of connection in terms of treating this underlying likely endocannabinoid imbalance in these patients. So I've treated hundreds and hundreds of children already with who have autism. Some of them have comorbidity with seizures. But this is what the parents report, and this is fairly routine. It's not every patient, but many of them. Less anxiety, and by the way, anxiety is a number 1 condition that parents come in for with these kids. Like, they just are so overly anxious. I can't tell you, I've actually met with patients like outside my building because they wouldn't come in the building or go up the elevator. less aggression towards others and self, better sleep, less rigidity, improved socialization, speech, communication, better focus. Some patients do have some improvement in the repetitive behaviors. What's interesting is that you can see patients improve in certain areas and not in others. What I'm finding difficult to treat in some of these kids are some kind of OCD hoarding behaviors, which are really interesting, and I've had to kind of really try other things with those patients to figure it out. So the current approach is trial and error, and don't let anybody tell you otherwise. You start a patient on either a combination CBD-THC or a CBD-dominant product. The studies, mostly from Israel, show that CBD-dominant will treat about 50% of your patients, and then you can start tailoring it down. If someone's aggressive or has severe insomnia, or severe anxiety, I'm always interested in using some THC in the beginning. But anyway, the point being here is that it's a really difficult process to figure out. These kids are all different, and it's trial and error at best, and it's based on parental feedback. It's time-consuming. It is incredibly labor-intensive for the clinician and for the parent. I make sure parents keep notes because one day can vary from the other, and sometimes you have to just look over time how many days were better and how many days weren't better, because there's just a lot of variability in the response. So the big question is, who might benefit? Can we pre-select who might benefit and save people time and energy and resources? Also, can we pre-select cannabinoids and products, and how do we assess the outcome objectively? And so this brings me to the research I'm doing with a company called Canformatics, and all of our papers are open source, so there's 3 of them online. If you just Google my name and put autism research, you'll find the papers. So this technology uses pharmacometabolomics, which is basically the systematic identification and quantification of metabolites in an organism or biologic sample. So we collect metabolites, which are compounds that make up what we call the metabolome. And this is just these compounds that reflect chemical pathways. They allow you to see what is happening in the brain. And it looks at phenotype versus genotype. So you can do the DNA studies, but DNA, remember, just gives you predictive. If the gene isn't turned on, it's not being expressed, it may not necessarily help you in determining how you should treat a patient. But when you're looking at the metabolites, the metabolome, it tells you what's going on in that human right at the moment that you're collecting that information. And this is just the way that the samples are collected. And you can do pharmacometabolomic or metabolome testing really on any biofluid, any tissue, cultured cells. And then what we do is we collect the samples and we send it in for nuclear MRS or mass spec. And then you look at your peaks and you kind of scale your raw data. And then you have reports that you can generate, including heat maps, and also you can put out pathway maps. And I'm going to show you examples of those as we go through this. And so this was the first paper we put out, and this was looking at the metabolites that we collected, and I'll go through how we did it. But really what we're looking at is metabolites that reflect the pathways that are involved in inflammation, bioenergetics, amino acid metabolism, neuronal activity, and the endocannabinoid system, trying to see, and really ultimately, just to make it simple, before cannabis, we collect a sample. After their dose, we collect a sample and we see what changed, what moved. Did it correlate with behavior? So we had 15 children with autism. These are children who were all on stable doses of medical cannabis, customized through my care, at least for 1 year, and we weren't changing anything so that we could see leave them on those stable doses for at least 3 months prior to the collection. 2 saliva samples were collected, and it wasn't a swab. They actually had to spit into a tube. We did it before they got their medical cannabis dose in the morning, and then anywhere from an hour and a half to 2 hours after they got their medical cannabis dose in the morning. And so about mid-morning. And by the way, this was during COVID. We started before COVID, so it got a little bit different during COVID, where we just had to be on the phone with the family while they were doing this. And then we did behavior surveys, and we taught the parents how to do the behavior surveys, and they did the survey at the same time as the first saliva collection and the second saliva collection. And then we had a sample of 9 children, typically developing, no evidence of any neurologic issues, no medical cannabis. We just grabbed a saliva sample in the morning, and they established our physiologic range, which you can see here. So I just want to show you this. This was kind of how we set up, how do we know what's in that physiologic range. So here's the patients 1 through 9 who are typically developing TD, and here's their average, and then we figured out standard deviations, and what we decided for our study was that greater than or less than 4 standard deviations away from the mean was considered out of the range and significant, and was actually correlated with symptoms. And what you can see here, this is just what the before cannabis and after cannabis, that was just our hypothesis of what it would look like. This is the characteristics of the patients, so I'm just going to show you here. We started with age 6 because under 6 is kind of hard to collect saliva, and we needed 1 ml of saliva. And so we went up to age 12. We were trying to minimize the effects of puberty, although we did see some effects of puberty. You can see mostly boys. This is how many doses a day that they were taking. So 1 dose would be in the morning. If it was 3 doses, morning, afternoon, and evening. Now, I just want to point out edibles and tinctures. These kids were all on tinctures. Nobody was actually taking a gummy. It's just we called it an edible if the parents were putting it in food. And then you can see each child's cannabis regimen, and you can see that there's nothing consistent. It's based on their own response, working very hard with the family to try to dial in using my rule it in or rule it out. And some of these kids, it took 2 years to find what worked for them. And remember that during the time that you're taking care of these patients, new cannabinoids are coming out. And then you want to maybe introduce something new after somebody's been on something for a while. Now here's the behavioral ratings before cannabis, and just to cut to the chase, red is severe behavior. The lighter colors are less severe, and we use 3 validated scales to assess this. The parental ratings of symptoms before cannabis, so 11 of the children were severe, 1 child was moderate, 2 children were mild, and we actually missed data on 1 of the kids. And then this is after. So you can see that this improved. 11 children were considered much improved. 2 children had mixed response, so improved in some areas but not in others. And 2 children actually had increased difficulties at peak, and it's quite possible that they were not happy about having to give another saliva sample and got, again, with the rigid behavior and so on, I always say, everybody's allowed to have a bad day. So these are the behavior ratings, and what you can see here is under this improvement, these are pretty high numbers here, and then no change, and then you see on the end some actual worsening for some of the kids. And so we detected 484 known metabolites in the saliva. 65 were identified as cannabis responsive, which means that we found that they moved after the cannabis dose towards the physiologic range in at least 8 to 15 in at least 8 of the participants. 31 of the metabolites were detected in all the participants, and 21 exhibited statistically significant shifts. And I'm not going to go, just because time-wise I don't have that much time, into how we calculated, but these are algorithms. They're explained in the paper, but it just gave us a way to measure the change and kind of sort out the z-scores. And so here, and I showed this yesterday, I think, I can't remember now, N-acetyl aspartate, which is one of the most abundant neurochemicals in your brain. It's the second most abundant after glutamate. And what we found, and there's already research that exists that shows that N-acetyl aspartate, which is involved in neuronal function and density and can reflect neuronal dysfunction, this particular compound has already been documented to be low in some individuals with autism or elevated in some individuals with autism, and the elevation was associated more with high-functioning Asperger's type symptoms. But what you can see here, so these are the patients along the bottom, A1, A2, A3, A5. So let's just look at A2. So A2 had very high NAA, prior to their medical cannabis. And what you see after they take their medical cannabis is it is much lower, and it's towards, this is the physiologic mean here established by the typically developing groups. You can see here they're all kind of tightly clustered around this average here. And then this gray line is the +2 or -2 standard deviations away from the mean. So what you see, though, is that look at A3, there's basically no NAA measurable, and then it comes up towards the mean. When it's high, as you can see in the older kids, they all kind of had high NAA. That all came down towards the physiologic mean. So here's some objective evidence of the homeostatic nature of cannabinoids, as well as shifting those compounds towards that physiologic range that was established by the children who don't have autism. So I was really excited to see this. I didn't think that we would see such great results. And then I showed this yesterday, and if you haven't seen this, this is just 3 of the older boys. This is plotted out. Here, go on this side. Here's your mean that goes down from the arrow, the -2 to +2 in the green column. These are all the metabolites listed on the left-hand side, and you can see kind of how they're all out of range. And then after medical cannabis, you see this is very crystal clear that what's happening and what the parents are reporting is we're seeing this incredible shift of these various metabolites. Remember, they reflect inflammation, neuronal function. They're correcting. Now, it seems to be a temporary correction, because if these are kids on cannabis round the clock or all the time, why are they having this initial, and this was 8 hours, at minimum of 8 hours without cannabis. So it's a temporary correction. So I don't ever want anybody to think that, quote, we're curing patients, but I do think what we're doing is giving them a natural, non-toxic option to have a decent quality of life and to live in a more physiologic balanced state. And so what we did was we decided to see if machine learning could help us understand more about our findings, and this was a report that we published in August 23. There was a second report, which I'm not including here, where we looked at just the lipid-based metabolites, but then we took all this data and we decided to see what machine learning could tell us. And so we had a lot of data. You see 3 categories of children. So we had typically developing children and their saliva metabolites, and then we had the category of children before they took their cannabis and those metabolites, and then the category of the same children but the metabolites after their cannabis. And then we had lots of metabolites to look at, as you can see in the corner down here. And then we looked at the correlation of these metabolites in these categories of children with just the 3 of the main cannabinoids. The other cannabinoids that you saw listed on that chart, including THCA, CBDA, and CBN, we just didn't have enough data, and there weren't enough children on those cannabinoids to be able to assess it. And so what we did was we created numerical scales for the dosing, and you can see here, and it was somewhat arbitrary, but we had to create some type of scaling so that we could feed the data in. And what you can see here is the dosing. Each dosing range got a number, each behavioral response got a number, and that was what we gave along with all the metabolite data sets. And so I can't include every finding, but I'm going to highlight kind of the most exciting findings here. So this is, I'm starting kind of backwards than what's in the paper, but basically we looked at differentially expressed non-cannabinoid plant metabolites, and we found 7 phytochemicals, including flavone, rutin. Rutin is a type of quercetin, vitexin, which is apigenin, naringenin, zeaxanthin, chloroxylic acid, and cytosterol. And they were all associated with shifting the cannabis responsive biomarkers excuse me, from large standard deviations away from the mean towards that physiologic mean. So what does that mean? And so all of these compounds have some evidence of being acetylcholinesterase inhibitors, which are involved in memory, learning, attention, motivation. Dr. Meckler mentioned acetylcholinesterase. And so what we found, though, and if you look here, What you can see is this gray bar is pre, so this is just, you can see that here. So before medical cannabis, this is coralsilic acid. This is where the kids sat with their metabolites and that for coralsilic acid. And then the second bar is after cannabis, and the third one is in the children who don't take cannabis. So why would it be there? Well, remember, it's a phytochemical, so it's maybe in salad or some other plant material that the child was taking. But notice that none of the others here were found in the typically developing patients. But the point being that these compounds were associated with improvements, and we hypothesized that this contributes to the idea of the entourage effect. That it's not just the cannabinoids, it's also these plant compounds, because these were found to stand out in the patterns that were discovered. Now here, this Venn diagram documents the identification of the autism cannabis responsive biomarkers that distinguish categories of the patients. And so machine learning found one particular compound that stood out to be different between the diagnosis of autism and the children without autism, and that's the one that's landing right here in the middle. And what you can see here is that before medical cannabis, it's this very wide variability, this wide range, and then with medical cannabis, it corrects somewhat closer to the typically developing, but it never achieves that kind of tight range. And so it seems that this particular compound called lyso-PE18-1 can distinguish between autism and basically make the diagnosis. So we're hoping to do further research on this, because currently, as we know, there is no test for autism, and we're hoping that just by collecting saliva, we might be able to have some support of the diagnosis. Again, remember, it's a clinical diagnosis where you answer questions, and it's somewhat subjective. Additionally, the machine learning documented that there was no evidence of any negative impact of cannabis, that no biomarkers moved away from the physiologic range, but this may be due to the fact that all of these patients were on cannabinoids that we knew were helping them, right? This was already personalized data, and I suspect that if you were to get a baseline before somebody started medical cannabis and you started some type of regimen, and then you checked the metabolites again, you actually might, especially if you saw unwanted behaviors or worsening sleep or something like that, we might see a shift away from the physiologic range. But the whole idea here is to try to understand these metabolites and use them as a tool to follow treatment and design regimens. And this is the last finding that I'm going to share, and to me it's the most exciting, is we discovered a number of biomarkers that were impacted by the specific cannabinoids. And so this is truly the understanding of the mechanisms of action. So we understand which receptors, which pathways CBD might affect, for instance. But we don't have the information of the underlying chemical status of the human being we're treating. We're making an assumption, and it's trial and error. And so this data can tell you about the baseline characteristics. So for instance, I'm just going to share a quick story. My parents live in upstate New York. It's dark most of the year. It's like not nice weather. And the doctor there, I had asked her to check their vitamin D levels, and she said, well, we don't check those, we just give everybody vitamin D. But wouldn't you want to know, I know everybody's shaking their head, you kind of know where you're starting and where you're ending up. I mean, that's kind of how we practice medicine. So needless to say, we don't go to her anymore. But point being that I want to know the baseline chemistry, and I want to know what these cannabinoids are affecting. I'm very happy with the fact that when a parent tells me the child is doing well, that's great, but what about the kids that I'm struggling to treat? Because not everybody responds the same way. I'd like to understand their chemistry. And so THC, we found, was associated with 11 different cannabis-responsive biomarkers. CBD was associated with 7 cannabis-responsive biomarkers, but really interesting, there was no overlap. So anybody who, we've heard over and over the past 2 days, THC plays a very important role. There are some people who are sensitive to it, but in general, if you are only using CBD isolate, you are missing out on some of these pathways and may not be achieving that full treatment that the patient might benefit from. CBG was associated with 15 cannabis-responsive biomarkers, more than THC and CBD, and there was overlap. Okay, so 3 biomarkers overlapped between THC and CBG, and only 1 overlap between CBD and CBG. But what's interesting is there's been some 2 reports in the literature reporting that CBG may have a reside pharmacologically between THC and CBD. It has and I think it was Dr. Russo who mentioned yesterday that CBG has overlapping effects with both. You can use a lower dose, but it's not impairing. And so that gives you a nice tool to be able to use in these patients. And I definitely see benefits with CBG in these kids. If you're treating kids with autism, do not ignore, you could start with CBD and THC, but definitely try CBG. I've seen a fair amount of improvement in speech, verbal abilities, and focus. All right, and then here, my research partners who are brilliant say this is simplified. I don't think there's anything simple about this, but we combined the machine learning data plus the information we gathered to create this metabolic pathway. And THC is in the green color, and you can see it's strongly linked to endocannabinoid metabolic pathways, including interacting with anandamide and 2-AG. CBG, which is in like the mauve color, was associated with 2-AG arachidonic acid and ethanolamine, which is a phospholipid. THC and CBG were also associated with variants of ethanolamine, which are also phospholipids. You can see those in the green with the red border. And CBD is in blue and was really associated with numerous lipid-based pathways that are involved in influencing oxidative stress. And up in the corner here, what you see, it says ASD and depression. What's interesting is we found some overlap in the scientific literature of these various compounds that changed quite a bit in response to cannabis medicine that were also involved in depression. And so how can we use these biomarkers? So we can use them, as I've mentioned, for diagnosis. Does this individual have the condition? They can be predictive. Will this patient benefit from medical cannabis? What if you get back, you do a saliva test before you treat, and everything is in the optimal range? Is that a person that you necessarily need to treat? I would still always offer treatment if there were issues, but at least it gives you that baseline status and have expectations. Pre-dosing, which I'm going to show you a slide. What about dosing and cannabinoid profile? What should we pick first? Response, how well is the individual responding? And also, what's the response over time? Is it maintaining? I will tell you that puberty really rocks this community. They become for many of them, they become much more aggressive. They have more sleep issues. They can be perfectly dialed in on their cannabis, and then they hit like 13, and all of a sudden it all falls apart. And I always call kids moving targets in the cannabis world because you're constantly changing things. But here I want to just show you one last slide. Oh, I have a perfect minute and 40 seconds. So here is the unhappy child that comes into my office, and this is their heat map. This shows you, and again, red is symptomatic, the dark blue is physiologic, and the light blue is optimal. So this child really does not have anything in the optimal range, and all that red there. And by the way, you can look at this, and then when you repeat the test, you can just compare the patient individually. But if we have a database, and here I have another patient who has a very similar profile that's already being treated. You can see, I think they're happy over here. And you can see that these, you get correction shifting towards that physiologic range. That gives us a chance to kind of dial in treatment and not have to be so trial and error and not have to look for every cue. And so it gives us a chance to follow these patients. So I'm really excited to do more research. This technology can be applied to, we're looking at doing some research with some people in New York for dementia. We're trying to work with some people in Canada to look at this for epilepsy as well. And then Ethan and I have talked about using this to see if there's any metabolic changes in patients with CHS. And so, there's a fair amount of application, and this at least is, by the way, you can send a kit to somebody's house, they can collect saliva and send it in. It's non-invasive and very easy and also low cost. So thank you very much. I'm happy to answer any questions.